Good morning. In this brief lecture, we are going to be discussing about sinus venosus defect, non-surgical correction using balloon expandable covered stents. I will simplify the procedure into 8 simple clinical steps. We have to understand the anatomy. Sinus venosus defect is intraarterial communication above the level of fossa valis, where the superior vena cava straddles the defect. So the SVC has got a biatrial connection, and the pulmonary vein, right upper pulmonary vein, invariably drains into the SVC just above the sinus venosus defect. If you look at the problems of surgical closure, by and large it is a safe procedure. However, 3 to 4% of the patients may get SVC syndrome. 1 to 2% of the patients may get right upper pulmonary vein stenosis. After many years, some of them develop sick sinus syndrome with tachybrady attacks, atrial fibrillation followed by sinus passes, and will need pacemaker implantation. Very unfortunately, some patients may develop SVC redirected towards the left atrium because of wrong patch direction. This happens quite often in minimally invasive techniques and in robotic surgery techniques. If you look at the anatomy in a CT scan, the right upper pulmonary vein drains into the SVC-RA junction. On a sagittal view, the SVC straddles across the defect with SVC connected to both the atria. If you position a covered stent, the covered stent routes the superior vena cava towards the cavity of the right atrium, and the pulmonary vein courses posterior to this covered stent and enters the left atrium. I will simplify the steps of this procedure into 8 simple clinical steps. The first one, bilateral femoral venous puncture. Through the left femoral venous puncture, take a standard broken bow needle, Mullin sheath, puncture the fossa valis, enter the left atrium. Confirm that you are in the left atrium. Step number 2. Clockwise torque this Mullin sheath so that it turns from the left side towards the right side of the left atrium and enters into the right upper pulmonary vein. A simple clockwise torque of this Mullin sheath will turn it towards the right upper pulmonary vein. Advance a pigtail catheter. Then make an angiogram in both SVC as well as this Mullin sheath. Mullin sheath will be a hand injection, SVC will be a power injection. Freeze the image when the contrast is filling both the venous structures and make a measurement. SVC diameter and the SVC anchor length. SVC anchor length is between the innominate vein to the pulmonary vein. Step number 3. Choose a long cylindrical balloon that is 4 mm larger than the SVC. Position it across the SVC-RA junction, inflate it, and make a simultaneous angiogram with the right upper pulmonary vein catheter. If you are finding that the right upper pulmonary vein is completely getting occluded, there is a possibility that this Mullin sheath is actually anterior to the balloon. Ideally, this Mullin sheath should be posterior to the balloon so that the pulmonary vein drains into the posteriorly placed left atrium. Turn to a lateral view and confirm that the catheter is correctly placed. Here you can appreciate the Mullin sheath is actually anterior to the SVC wire. It should not be the case. It should be like this, posterior. So if you identify that the Mullin sheath is anterior, pull back the SVC wire and re-advance the SVC wire. Step number 4 is repeated now by placing the Mullin sheath posterior to the long cylindrical balloon. Here you appreciate that the pulmonary vein is completely routed into the left atrium. There is no filling of the right atrium. So that means the sinus venosus defect is closed completely. the pulmonary vein is not obstructed. You can check the pressure in the pigtail catheter and you can check the pressure in the Mullin sheath and record the gradient between the two. The next step will be to put in a long covered stent on the same balloon and deploy it across the SVC-RA junction. If you have any concerns about pulmonary vein getting partially occluded, you can put in a protective balloon on the back. The protective balloon is typically a 12 to 14 millimeter long balloon, whereas the covered stent balloon is the same as the balloon that was used for interrogation. The protective balloon is inflated at around 10 atmospheres, whereas the long covered stent is often deployed at 3 to 4 atmospheres. Then advance the Mullin sheath into the left atrium and repeat an angiogram. And in that angiogram, confirm that the pulmonary vein is routed towards the left atrium. Covered stent is in good place. And in the lateral view, if you have used a protective balloon, the covered stent is having a posterior indentation. Advance the marker pigtail catheter through the covered stent into the superior vena cava and do an angiogram and find out how much is the recoil compared to the original balloon that we used. Repeat a Mullin sheath angiogram to confirm that the pulmonary vein is completely redirected towards the left atrium. At this point, a brief transesophageal echocardiogram. This is the TE long axial view. Superior vena cava is directed towards the left atrium. There is no flow across the sinus venosus defect. A gentle clockwise torque of the TE catheter, TE probe. Right upper pulmonary vein is completely routed towards the left atrium. So, the basic steps are to have a long cylindrical balloon inflated across the SVC-RA junction and confirm that there is a complete cessation of left right shunt. Right upper pulmonary vein is unobstructed and the pressure gradient is not more than 2 millimeters of mercury. Some of the caveats in this procedure are presence of an additional secundum ASD. If there is an additional secundum ASD, when we are doing the balloon interrogation, the RUPV angiogram will fill the LA, but then the contrast will flow through the secundum ASD into the RA. So you have to use two balloons. One balloon, a sizing balloon to interrogate the secundum ASD, and a long cylindrical balloon for the sinus venosus defect. And here you are finding that pulmonary vein is getting routed towards the left atrium. Then you close the secundum ASD with a standard ASD device and close the sinus venosus defect with a long covered stent. So this is a ASD device and a long covered stent. Sometimes if there are multiple ASDs, do the same thing for all the ASDs. So this is a superior secundum ASD, this is an inferior secundum ASD and a sinus venosus defect. So these are two balloons. So you're positioning two devices and a long covered stent. The same principle. The second caveat is patients who are having high pulmonary artery pressures and you are suspecting that they may have a pulmonary vascular disease. When you are doing this balloon interrogation, you can advance a catheter into the pulmonary artery and record the pulmonary artery pressure simultaneously. When the balloon is inflated and the sinus venosus defect is closed, you can appreciate the right upper pulmonary vein draining into the left atrium. With complete closure of the defect, and the PA pressure actually falls. Originally, we start off with a 68 peak pressure and a mean pressure of 40. And during the balloon interrogation, it drops down to 26 peak pressure and a mean pressure of 70, indicating that the PA pressure is hyperkinetic. The third caveat is what happens if there is a right upper pulmonary vein contrast stasis or a minimal increase in the pressure. In this example, the right pulmonary vein is getting redirected towards the left atrium, indicating that the patient is suitable for a correction, but there is a mild contrast stasis here. So in these cases, as I pointed out earlier, we use a protective balloon. The protective balloon is typically a 12 to 14 millimeter balloon expanded at around 10 atmospheres. You will get an unobstructed pathway from the right upper pulmonary vein towards the left atrium. This protective balloon will be needed in almost 1/3 of the patients. Caveat number 4 is presence of additional high draining additional pulmonary veins. That is beyond the right upper pulmonary vein, there are some more smaller additional pulmonary veins draining in the high superior vena cava. This happens in about 16 to 17% of the patients. So this is an example of a high draining small additional pulmonary vein and the main pulmonary vein. So you are interrogating the main pulmonary vein, and during balloon interrogation you find that the main pulmonary vein is getting redirected towards the left atrium. So this is epicranial and this is levoradial. We close this patient's ASD with two stents. There is a bare stent at the top and a covered stent at the bottom. Both are inflated simultaneously. You position the bare stent in such a way that that will drain the additional pulmonary vein inside the superior vena cava, as shown in this image, and the covered stent across the main right upper pulmonary vein so that the right upper pulmonary vein is redirected towards the left atrium. Nowadays, we have a hybrid design stent. So this is an example of an additional high draining pulmonary vein plus a main pulmonary vein. So in this case, the main pulmonary vein is redirected towards the left atrium on balloon interrogation, but the additional pulmonary vein is getting occluded on balloon interrogation. So what we do here, we choose a hybrid design stent. So the stent is 8 centimeter long, with the top 15 millimeter being uncovered and the bottom 65 millimeter being covered. You park it on the long cylindrical balloon, but before crimping, advance a guide catheter through it. So there is a parallel guide catheter, right coronary guide catheter, with the balloon, both together, and the stent is now crimped. And you put in a protective sleeve, and this whole assembly is now taken into the sheath, long sheath, and the long it is pushed through the long sheath. This we recently published it in the Journal of Society of Cardiovascular Angiography and Interventions. So here what we do is we park two simultaneous wires, one in the jugular vein and one in the right upper pulmonary vein, the additional pulmonary vein. So the RCA guide catheter goes through this additional veins guide wire, whereas the main guide wire will support the balloon. So you go ahead and deploy, and so invariably the additional pulmonary vein will drain into the superior vena cava. So this is that additional pulmonary vein draining into the superior vena cava. The next caveat is a very short SVC anchor zone where there is inadequate anchor. So in that case also we use the same strategy, the same hybrid stent. So this is a very short SVC anchor zone, just 1 centimeter. So what we do here is we take the RCA guide catheter through the junction between the bare stent and the covered stent and advance it towards the left innominate vein, so that the bare part will be in the right innominate vein and the covered part will be in the superior vena cava. Once we inflate, we can appreciate that the innominate vein is draining through the side struts of this hybrid stent and draining into the main covered stent. We have used this current strategy in a little more than 150 patients now. Our inclusions have increased to almost 94% of patients with sinus venosus defect. We had 2 embolizations of the covered stent in the cath lab, which we fixed with additional covered stents, but 3 embolizations that happened earlier in our experience where we have to send for surgery. So 3 out of 150 failure rate, which accounts to almost 98% success rate. In the recent times, what we do is we use a lot of virtual reality software. If you look at this CT scan, we are rendering the heart. This is the superior vena cava. This is the left innominate, right innominate vein. This is the right upper pulmonary vein draining into the SVC-RA junction, and this is the sinus venosus defect. So here we crop the heart and we virtually implant a stent. So what we do here is we take a stent which is about 4 millimeter larger, and this stent is picked up and positioned across the sinus venosus defect, and then we look at it in cross section. So here we can appreciate the right pulmonary vein pathway posterior to the covered stent draining into the left atrium. So there are ways in which now we can, by virtual reality, holography, we can understand the anatomy far better. There are many publications which describes all these steps in a very stepwise manner. So dear friends, I will conclude this talk by telling that this sinus venosus defect covered stent exclusion is a new catheter option, and almost 94% of the patients are suitable for this procedure. Patients who are older than about 5 years of age and those who are older than about 14 to 15 kilogram body weight, who will be able to take a stent of at least 16 to 18 millimeter in their superior vena cava are suitable. Ideally speaking, if there is a single right upper pulmonary vein, it's good. But if there are additional pulmonary veins, we should be able to protect those additional pulmonary veins by putting in a hybrid stent or a bare stent at the top. This additional pulmonary veins are present in almost 17% of the patients. That means 1 out of 6 will have it. Additional secundum ASD will be present in about 6 to 7% of the patients, and they will need additional devices. Pulmonary vein protection strategy using a 12 to 14 millimeter balloon expanded through the Mullin sheath will be needed in almost 1/3 of the patients, and this has grossly increased the patient selection. Almost everybody will be suitable now if you are using a pulmonary vein protection setup. We do this procedure completely as a fluoro guided procedure, so the patient is conscious, so we can assess the hemodynamics very accurately. We can check the pulmonary artery pressures if we have any doubts. But if the patient is having a renal failure or some contraindication for contrast injection, we can do it intubated with totally transesophageal echo guided. There is no need for doing contrast at all. In patients who are having short SVC anchor zone, they are prone for embolization, and these patients are benefited by the new hybrid design stent. We try to keep the transesophageal echocardiogram as minimal as possible only to the end of the procedure. So it increases the patient comfort and the patient is very comfortable throughout the entire procedure. Thank you very much for your attention, and I am happy to take any questions. Once again, I thank you for this opportunity.